about aortic stenosis, what is the causes, how you have to work out based on the 2020 guidelines of the ACC and also American Society of Cardiography, echocardiography guidelines. So first of all, like, this image this is the normal rheumatic. You're going to have commissural fusion, calcified aortic valve, and bicuspid. Always you have an echocardiography to evaluate it is bicuspid or tricuspid in systole. Why? Because you're going to see the opening of the valve. The first thing that you have to understand is how is going to be the workup. In this image taken from the guidelines, is basically why you have to do for workup. But this is an oversimplification. So I'm going to explain step by step, and we are going to understand later on what is each point of this diagram. The etiology. What is the most common cause of aortic stenosis? Calcification of tricuspid valve. Another common cause is bicuspid aortic valve. Why you have to know about bicuspid aortic valve is most of the time arthropathies associated with bicuspid aortic valve. The most common like fusion of the when you have like a fusion is the right and left. That's gonna be anterior cusp, and it's 80% of the time. 20% is gonna be the right and non-coronary cusp. So and so meaning like the right and left make the anterior cusp and the non-coronary cusp make the posterior cusp when you have like this configuration, which is the most common. Rheumatic is always to keep in consideration. Why? Because it's the most common worldwide. What is the characteristic of this? Is commissural effusion. Rheumatic aortic valve is always to keep in mind. Why? Because like people who move from low resources country to high resources country like United States, you are gonna think of rheumatic if they have aortic stenosis, especially if they are young. Normal area of the aortic valve is important to keep in mind is 3 to 4. If you have like a severe aortic stenosis, it's 25% of this. So most of the time is less than 1 centimeter. Aortic sclerosis is an important concept. I'm gonna tell you right now. Just keep in mind because you are gonna see in the guidelines later on. But it is a focal areas of calcification and thickening with a velocity less than 2 meters over second. What is the assessment? To assess the aortic valve, you have to understand what is the eject velocity, what is the mean gradient, and what is the valve area by continuity equation. I have like a common like a example of what is aortic stenosis. Imagine like you are in the room and there is 100 people in the room, and outside of the room you want to get outside of the room, but there is a tiny way, a tiny like door. So all the people trying to get through that door. So the velocity through the door is going to increase. Or the same thing with a hose of water. If you have like a narrowing, the velocity is going to increase. And the gradient is between two cavities are going to be huge. Why? Because the velocity through that is going to increase. So you are making more pressure from inside to outside. And we're going to understand all of this concept in the next slides. So the first thing that we're going to talk about is a peak jet velocity. Peak jet velocity is basically measure the maximum velocity that goes through that area. How you do it is with echocardiography, you put it like a continuous wave Doppler. So what is that? You measure the highest velocity through that line. You can use, if you are familiar with echocardiography, you can use apical views or right parasternal view is the most common. You can use also color Doppler to guide you, like where is the turbulence of that, like the to measure like the aortic stenosis flow. Avoid eccentric MR. This is a good clue. Why? Because if you have eccentric MR, you may confuse with like the aortic jet, and you may have like a higher velocity. You always have to average 3 beats in your sinus or 5 beats if you are an irregular beat, such as atrial fibrillation. Avoid post extrasystolic beats. So here you have like an example of aortic stenosis. You can see 5.4 is severe. So this is a continuous wave Doppler. Why? Because you're trying to measure the highest velocity. Now, you have like 3 examples here, 1, 2, and 3. You see like it's a little bit different, those figures, right? Here is more rounded. Here is and triangular. Here is more like triangular here is more rounded, and here is look like it's speaking like later on. So just seeing those figures, you can already get like what is severe aortic stenosis and which one it is not. So the first one is moderate aortic stenosis that you can see mild, early peak, and triangular shape. Triangular shape. Then you have like this is severe 5.4. The prior images this is. As you can see, it's more a rounded curve and late peak in mid systole. If you have like your electrocardiogram, it's gonna be in mid is systole the peak. This is more like early peak. And this, what is this? This is a common like example of how come that you pick late because it's dynamic obstruction. I'm gonna make a video about this. So just keep in mind, like if you see the image, this is aortic stenosis. If you see this, this is no aortic stenosis. This is a common feature, a common characteristic, a wave or like HOCM. Now we're gonna understand what is gradient. Remember, gradient is the difference between two cavities. You can measure in echocardiography or and you can measure like with the CAT. Those are the most common like type of measure the tools that you have to measure like the gradient. You can use other tools like other tools, but those are the common ones. So mean gradient, you see, is the darker here. Is the mean gradient between two cavities. But you also have like a peak-to-peak gradient, and you have like a peak instantaneous gradient. What is the difference? Peak-to-peak gradient is this. You measure the peak here of the aortic, the peak here of the peak of the aortic, and the peak of the left ventricle. This peak to peak, you measure by CAT when you are doing catheterization. And this is almost similar to mean gradient. Now, peak instantaneous gradient is this, is the lowest point to the highest point. And sometimes, and it is like two-thirds, the mean gradient is two-thirds of the peak instantaneous gradient. So why is important this? Why? Because Bernoulli equation. Bernoulli equation is this equation, 4 times velocity times square. If you have the velocity, you can calculate the gradient. When you calculate, for example, a velocity is 4. 4 times 4, 16 times 4 is 64, right? But hold on, I heard that severe aortic stenosis is more than 40. Why 64 more than 40? Why? Because 64 is the peak instantaneous gradient. Is the difference of here to here, here to here. The mean gradient is this, the difference here, and it's a calculated number. So the mean gradient is this. Another concept that you have to understand is this is a simplified Bernoulli equation. The most extended Bernoulli equation is you have to have like the proximal velocity. You usually ignore the proximal velocity because it's less than 1 millimeters over second. For example, you put like the pulse wave Doppler in the LVOT, which is like below the aortic valve, and it's less than 1, you can forget that. But uh, uh, if the proximal velocity is more than 1.5 and the aortic velocity is less than 3, you have to take in consideration that you are going to use this more extended version of the Bernoulli equation. And you may have, then you are going to calculate the mean gradient. Now, what is pressure recovery? Why we care about pressure recovery? Pressure recovery, as the names imply, the pressure recovery distally to the point of stenosis. So imagine like you have like a velocity here, 0.1. Velocity 2 is in this narrowing, increase the velocity, but the pressure lowers here. So the difference here is going to be higher. And then in third point here, the pressure is going to recover. If you measure the pressure gradient between 0.1 and zero point 0.2, is going to be higher. It's going to be fastly like a the gradient is going to be increased, falsely increased. But you measure the pressure gradient between 0.1 to 0.3, it's going to be lower. So that is why like echocardiography sometimes measure zero point 0.2, and that is an overestimation of the gradient. And when you go to the catheterization, oh, the gradient is not that high. Why? Because you don't measure in this, you measure like the true gradient between 0.1 and 0.3. When you take in consideration, especially with the ascending aorta is less than 3 centimeters. That is important. It's less than 3 centimeters. You have like a huge gradient, and the valve is more than 1 centimeter, like so, like the data doesn't match up. So take in consideration that could be a pressure recovery, meaning you are measuring from point 1, from point 2, and the pressure is vastly low. That's why like the difference is higher. That this is the same concept. Point 1, point 2, increase the velocity, but the pressure gradient is higher. Point 3, the pressure is recovery, so the gradient, this is the true gradient. If you measure from point 1, from point 2 with echocardiography, that's going to be abnormally higher, the pressure gradient between 2 points. Now, what is a continuity equation? Continuity equation meaning like if you have like a stroke volume, so meaning the amount of blood that goes from this point, LVOT, has to be the same amount of blood that goes through the aortic valve because it's a continuity of the system, right? The same amount of blood that I have in the LVOT has to be the same amount of blood that goes to the aortic valve. How you calculate the amount of blood, the stroke volume? Basically, the calculation is the area times BTI. BTI is a velocity through time. What is like the velocity doing through a time of the blood going through like the specific like area, a part of like the heart that is going. So if you have like if you know like the area of the LVOT times the BTI of the LVT has to be equal to the area of the aortic valve times the BTI of the aortic valve. Now, if you put it, for example, a pulse wave Doppler here, you are going to have like the BTI of the LVOT. And if you have like a continuity equation, you're suspecting the highest velocity is in the aortic valve here, the highest velocity. So you can just arrange your formula and multiply the valve area of LVOT times the BTI of the LVOT divided by BTI of the aortic valve. And then you are going to have the aortic valve area. This is by continuity equation. Sometimes when you do a dobutamine stress test, you don't the LVOT you don't measure. Why? Because the LVOT size is constant. You just measure the BTI of the LVOT and the BTI of the aortic valve. We're gonna see more examples later on. So the same thing, how you measure the LVOT of area. So you just measure the diameter diameter here, mid-systole, you measure and you use this formula, but a better simplifier of this formula is this. So this is P times D divided by 2 square 2. This is radius, by the way, D divided by 2. But if you want like a more simplified version of this is 0.785 times a diameter square. Where is this 0.785 comes from? Is from this formula here. So now, what you do to have your LVOT VTI. So you put like a pulse wave through the LVOT and you're going to have the VTI. The VTI is all of this that I am marking this. So now you have like the area. By the way, here you are going to measure from inner edge to inner edge. Like usually they say like in the guidelines 5 to 10 millimeters from the aortic valve. So you measure you have like diameter, you multiply for times 2 and you multiply 0.785, then you have your area and then you have like your BTI. So you have like the first part of equation here. This is another way to just measure, just an example. Usually you avoid this calcification here. You can measure 5 to 10 millimeters before the aortic valve. By the way, if you measure here, the pulse wave Doppler also has to be in the same place. So for having an accurate number. Then this is an example how to measure the diameters of LVOT. So you see, avoid the calcification here. Try to avoid is usually 5 to 10 millimeters from the aortic valve. And then don't forget. So you measure the LVOT, you multiply the formula, you have like the diameter times square times 0.785 and then times BTI of the LVOT that you obtain by pulse wave Doppler divided that BTI of the aortic valve obtained by continuity equation. You also have like a different also like alternate measure or like to like knowing like what is like severe aortic stenosis. DVI, this is a dimensional index. What is that consist? You're gonna forget about like the aortic valve. Now you are gonna just divide the BTI of the LVOT divided by BTI of the aortic valve, and if you have less than 0.25, meaning like 25% of that, that tells you like that is a severe aortic stenosis. You can also do with velocity as well. If you don't have like the BTI, you can do with velocity, and that give you like a rough estimate. Oh, this may be like a severe aortic stenosis. The next thing you can do is planimetry. What is planimetry? Planimetry is looking the valve and kind of like a marking like what is the area that I am seeing when I am doing like, for example, a TE is more common, like transthoracic echocardiography. You can also do a planimetry, but I haven't seen that done. Usually it's done by when you are doing transesophageal echocardiogram. What is effective versus anatomic area? Effective is this, when you are calculating through continuity equation, then you are having effective. Anatomic area is planimetry. What is better? Effective, because that is telling you like what is going on, what is the area that you, is the flow is going. Now, recommendations. This is a rough, this is like what is the guideline says. This is taken from the American Society of Echocardiography. For severe peak velocity 4 centimeters, mean gradient more than 40, aortic valve area usually less than 1. Index, if you index by body surface area, zero point 0.6, less than 0.6, and dimensional index less than 0.25. This is the range of severe aortic stenosis. So pretty easy. 440 less than 1, less than 0.6, less than 0.25. Remember, mean gradient is a calculated number. So you have like more than 40. What is the mean gradient more than 40 the velocity? What is the mean gradient more than 40? Now, what is mile? Mile is 2.5, less than 20. Aortic valve area more than 1.5. Index more than 0.85, and velocity radio more than 0.50 or 50%. Aortic sclerosis, we talked about like earlier. Why is important? Because when you have like a velocity less than 2, in this case here less than 2.5, that although is calcified but doesn't have a higher velocity, you're going to call this aortic sclerosis. Why is important? Index the valve area. You can see why is important, because if you have like a person of 7 foot and he has like a 1.2 centimeters, actually it's not severe if you go. But if you index that, could be less than zero point 0.6. So meaning like the valve, even though for a person who is like a 5'9" feet is normal, for that person who is huge, who is big, 7 foot, could be narrow. So index uh, don't use in obesity. Why? Because you have like more a higher surface area. Yes, for children, adolescents, and small adults. Again, if the valve area in like a person who is like a 4 feet, 5 foot, right? Is like put it like a number, like a zero point 0.8 centimeters. You say like, oh, it's small, but if you like index for that person and it's like more than point eight four eight five, that is mild, so that is not severe. So index, keep in mind, in obesity, it could be like falsely like a lower the index. Why? Because you have like more area in obesity, and it's okay for children, adolescents, and small adults. Now, you have a combination of this. You have like velocity and you have gradient, right? High gradient, more than 4, mean gradient, more than 40. Low gradient is less than that. Just keep in mind, high gradient is this, low gradient is this. Then, what is normal flow? Normal flow is the stroke volume index of more than 35, low flow is less than this, and ejection fraction preserved is more than 50, and ejection fraction low is less than 50. Why is it important? Because we're going to have a combination of those to classify what is aortic stenosis. Remember, high gradient is more than 4, more than 40. Low gradient is more less than that. Normal flow, more than 35. Low flow, less than this. Ejection fraction preserved is more than 50%. Ejection fraction low is less than 50%. Why is that important? We will see like early in the next slide. Yes. Why is it important? Because there is discrepancies, right? If you have an aortic valve area, but a severe gradient, that is usually because you have like more flow going through the valve. For example, in case of aortic regurgitation, more blood is coming to the LV, more blood is ejecting from the LV. You have anemia, you have hyperthyroidism, or you have like a shunt lesion, for example, like when you have like hemodialysis. Now, if the aortic valve area is less than 1 centimeter, that still is severe, but you don't have like a severe gradient. Why? Is because the flow going through the LV to the aortic is low. That's what we call low flow, low gradient. Low flow is a stroke volume index. We know how to calculate stroke volume. Stroke volume is calculated the diameter of the LVOT. From that diameter, I'm gonna have like the area. How you calculate diameter square times 0.785 and times BTI. And then I index for the body surface area. If my stroke volume index is less than 35, that's like I have like low flow and the ejection fraction is 50%. What I'm gonna do there? I'm gonna do a dobutamine stress test. Why is dobutamine stress test? Because it's gonna increase the ejection fraction. When increase the ejection fraction, I have like a good flow, a normal flow, meaning more than 35, then I'm gonna see the true severe aortic stenosis. But if I don't see severe aortic stenosis, meaning like the velocity is no more than 4, that is what we call a pseudo-severe aortic stenosis, and this is moderate like aortic stenosis, doesn't need to be addressed at this moment. Needs to be followed, yeah, but there doesn't need a replacement or other kind of like an intervention. Thing. Low flow, low gradient, low EF, meaning like you do a echocardiogram, the aortic valve area is less than 1, but the velocity is no more than 4 or the gradient is no more than 40. So what you do? You do a dobutamine stress test. Why? Because the ejection fraction is low. So with the hope, if you increase that ejection fraction, you're gonna increase, but you're going to increase your stroke volume and you're going to increase the flow, and you will see if you have like high gradient, high flow, high flow, high gradient like aortic stenosis with that increase of stroke volume. So first of all, how you do the stress test? I I'm gonna do a different lecture later on about the vitamin stress test, but this is an in summary. You start with 2.5 to 5 micrograms kilogram minute. This could be done by the nursing. So remember, use this 2.5 to 5. You increase 2.5 to 5 every 3 to 5 minutes, maximum 20. So, and then you are gonna measure your velocity in each state until the peak. What is the peak? So infusion stop when the maximum dobutamine dose is reached, so meaning 20. When you have like a positive result of 10, meaning that if you increase to 5, then you increase to 10, and in 10 you have like a velocity more than 4, you stop because that is a positive result. The heart rate increase 10 to 20 over baseline or exceeds like 100 beats per minute. If you have this, you stop. And if you find like the velocity was less than 4, that tells you that is a negative test. Or the patient has symptoms, blood pressure falls or significant arrhythmia. You have to stop there. And you want to see a more than 20% increase of a stroke volume. Why? Because if you don't see a more than 20% of increase of stroke volume, you still may have severe aortic stenosis and you may use other tools to diagnose that. By the way, the LVOT is measured at rest and used throughout the study for continuity. Why is it important? Because when you just measure, you just have to measure the velocity. The LVOT measure is going to be constant there. DVI, you can use DVI in this. Measure EF at each state. So positive result. When is positive result? An increase of aortic valve area more than 1 suggests that stenosis is not severe, it's moderate. Severe stenosis is suggested by increase of the velocity more than 4 or the gradient more than 40, providing that the valve area doesn't exceed 1, so doesn't go against the first point at any flow rate. The absence of contractile reserve, failure to increase the stroke volume by 20%, is a predictor of surgical mortality, a poor long-term outcome. So, what is severe? You find this more than 4, more than 40, and with the aortic valve area less than 1. If the aortic valve area goes more than 1, it's not severe. So, this is straightforward. The Butermin stress test, you ask for low gradient, low flow with low ejection fraction. To increase the ejection fraction, increase the flow through that area. When it's positive test, when you see those parameters, more than 4, more than 40 in each state. You start 2.5 to 5, you increase 2.5 to 5 every 3 to 5 minutes until 20. When you stop, when you have like a positive result, when the heart rate increases 20 to 20 beats per minute over a baseline, or when it exceeds like 100 beats per minute, when you have symptoms, obviously, and when you have like a more than 20% increase on the stroke volume. So that is a Butermin stress test, okay? So how will you report in Butermin stress test? You report the velocity, you report like the mean gradient, you report like the stroke volume, the aortic valve area in each stage, and ejection fraction, baseline and peak effect. Those are the parameters that you have to report in Butermin stress test based on the guidance. Now, low flow, low gradient with preserved ejection fraction. We saw a low flow, low gradient with low ejection fraction with the dobutamine. Now, what we do with this preserved ejection fraction, things like, oh, the heart is pumping well, but something is causing that you don't have like you don't have like high gradient. So that is what we call paradoxical low flow, low gradient, severe aortic stenosis. So what is the common causes of this is because the left ventricle is hypertrophied. It's small, so doesn't have like enough volume there. That's why you don't generate enough like flow. Your stroke volume is less than 35. Although your ejection fraction is good. Ejection time is prolonged despite low flow. So normal stroke volume. So meaning like you like a long time to eject like that volume, but you don't generate like a flow like during that time enough flow. So that is why like you have like a low flow, low a gradient preserved ejection fraction. Also, always you have to remeasure aortic valve area when you have like severe hypertension. Why? Because you may have underestimation of the LVOT gradient. Why? Because you increase the afterload. When you increase the afterload, so you are gonna have like a underestimation of LVOT area based on the continuity equation. Unlikely if the velocity is less than 3 meters over second or the gradient is less than 20. If you have like this, it's unlikely this is a low flow, low gradient. What is the characteristic? You are going to have like a physical symptoms consisting of severe aortic stenosis. Usually those people are elderly, more than 70 years old. And what you have to do then, you're not going to do the vitamin. Why? Because the ejection fraction is good. What you're gonna do? You're gonna do a calcium CT of the aortic valve to measure the calcium. What is positive? In males like more than 2,000 Hounsfield unit, and in women it's like more than 1,200. That is likely. Very likely is more than 3,000, and in female is more than 16,000. And very likely, as you can see, is less than 1600 and women like less than like 800. So that is important, those values. Specifically memorize this. More than 2000 male, more than 1200 in women. That is tell you like severe aortic stenosis. Sometimes with the Butermin stress test, it's not conclusive. You may use the calcium score by CT. So then you have like a normal flow, low gradient aortic stenosis with preserved ejection fraction. This doesn't exist, it's moderate. So meaning if you have like normal flow aortic stenosis, you calculate with preserved ejection fraction and aortic valve area is than 1, probably is moderate. So you don't have this. Now we're gonna go through the chart that we saw at the beginning. So you're gonna start aortic stenosis with your physical exam. Physical exam, you notice a murmur, right? That is the first thing. Then you order an echocardiogram. Then you are gonna see the morphology. If the morphology is suspicious of aortic stenosis, then you are gonna measure the velocity and the gradient. Then, if you have a high gradient aortic stenosis, the velocity is more than 4, the gradient is more than 40, the next thing is like, okay, you have aortic stenosis. Hold on, you have to evaluate the patient has high flow status. High flow status is like, for example, like stroke volume is more than 58. They mention in the guidelines. The patient, for example, has fever, has anemia, pregnancy, has like a hemodialysis. You have to make sure like this is not high flow status, but the patient has like aortic regurgitation. This is high flow status. That tells you like it's a high gradient aortic, high gradient because of those pathologies. So you may not have like severe aortic stenosis. If that is not the case, you see if the you may have like a high severe aortic stenosis. Severe aortic stenosis. If that is the case, you have to see if this is reversible versus irreversible. For example, it's not reversible. The patient has like an aortic rotation. The patient in hemodialysis, so meaning you have a shunt, you have like severe aortic stenosis. It is reversible, meaning like the patient is pregnant, is pregnant. The patient has like a thyrotoxicosis. The patient is anemic. You have to reassess when those pathologies are correct. So I think like this is clear. You measure the velocity gradient. Velocity is high, gradient is high. You have to make sure you don't have like a high flow status. The high flow status doesn't exist. You have to make sure it is reversible or irreversible. If it is irreversible, such as aortic regurgitation, you are gonna like already classify as severe aortic stenosis. If it is reversible, you have to remeasure when those conditions are dealt. If you have like low gradient aortic stenosis, like less than 4, less than 40, what are you gonna do? Assess the aortic valve area. Is more than 1, probably is moderate. You can use also like the index here. Why? Because in people who are tall, people who are small, sometimes those bad area doesn't correlate pretty well by their body, by the body size area. Aortic valve area less than 1, so always check your measurements. But then you're gonna see like the stroke volume. Stroke volume is low or normal. If it is normal stroke volume, severe aortic stenosis is unlikely. Why? Because with normal aortic stroke, normal flow, and in the valve area less than 1, you may have high grades. But you don't have is moderate. If you have like low stroke volume, less than 35, then EF, you have to evaluate EF. If the EF is normal, more than 50%, then you use CT scan. If less than that, you do like the Muramin stress test. Then, if you don't have like flow reserve, meaning like no more than 20% of your stroke volume increase, you still are gonna use the calcium score by CT or the aortic valve. If your flow reserve, you have a good flow reserve, more than 20%, then you may classify it as a true aortic stenosis or pseudo severe aortic stenosis. So then we're going to continue what is exercise stress echo. What is important exercise stress echo? Sometimes you may have asymptomatic severe aortic stenosis. You want to see the functional status, but you also want to know like the aortic severity. For example, you have like a valve area of less than 1, but the velocity is not that high, and you don't, and the patient is asymptomatic. You can use exercise stress echo. Not recommended for assessment of aortic stenosis severity and recommended for functional class. So functional status, and you can also evaluate that, but it's not recommended for assessment of aortic stenotic severity. Then we're gonna talk about like a different type of condition that can affect our measurements. LVH, a small cavity, a small stroke volume. That can give you what? If you have um, severe aortic stenosis with a normal ejection fraction with low flow. That is a typical cases that give you that when in the early. That's what like you use calcium score in those cases. You can use continuity is accurate because like the same amount of flow goes through the LVOT, the same amount of flow goes to the aortic valve. Index of the aortic valve if the patient has like a small body size, as we discussed previously. Hypertension, always. Never, never, never evaluate the aortic valve when the blood pressure is more than 140. So the systolic blood pressure has to be less than 140 for the, the data to be accurate, the measurement to be accurate. So make sure if you have like a severe aortic stenosis and you have like a blood pressure more than 140 and the aortic valve area is less than 4, but the velocity is not that high. We measure when the blood pressure is normal. Why? Because this could be vastly abnormal. Aortic regurgitation, as we spoke about it, can give you like a high flow status. So if you have like moderate aortic stenosis and moderate like AS, this is severe combined valve disease. So that may require like intervention on that. Mitral valve disease, careful with the MR jet. Already spoke about it. Why? Because the MR jet is a high jet, high velocity jet. If you have like a MR, severe MR, that can give you a low flow, low gradient. Low flow, low gradient. Why low flow, low gradient? Because all the blood goes to the LA, to the left atrium, because you have like a severe mitral regurgitation, and you don't have like enough flow going to the LVOT. That is why, in those cases, if you do dobutamine stress test, you're going to increase the ejection fraction, right? But all the blood is still going to the left atrium. So in those cases, I would use CT calcium score. Mitral stenosis, low cardiac outflow, low flow, low gradient. Why? Because no enough blood go to the LA, and there is no enough no enough blood going to the LVOT. And also like ascending aorta, if you have like disease there, also can give you like a abnormal parameters there. What is the treatment? Treatment always symptomatic, asymptomatic. All when you have like a peak velocity more than 5.5, you have like a rapid increase 0.3 meters second year, or increase of the mean gradient with exercise more than 20%. You are going to treat this. We're going to see in the guidelines in the next couple of slides when you have like class 1, class 2A, class 2B, and all of that. This is the guidance. It's confused. A lot of stuff there here. You don't have to know this. Besides, it's A, B, C, D. A, arrest. B is progressive, mild to moderate. C is asymptomatic. D is symptomatic. And then you have like a different stuff that I did for you. A, arrest. You have like the bicuspid aortic valve or sclerosis, meaning like the velocity is less than 2, it's calcified. This is arrest. So, progressive. Rheumatic already is progressive, the velocity is more than 2. Normally F. So this is mild to moderate. Then you have like stage C asymptomatic and stage D symptomatic. Stage C asymptomatic, you have like class 1 and class 2. Class 1 is normal EF, class 2 is low EF. Then you have symptomatic. You have like 1, 2, and 3. 1 is high gradient, 2 is low gradient, low flow, low gradient, low EF, and 3 is low gradient, normal EF. So we're gonna see when we do each of things, or the workup for each of one of those. So first, symptomatic, asymptomatic, right? One, this is a asymptomatic severe aortic stenosis, or very normal EF. Then you do exercise testing to see if you have symptoms. If you have symptoms, this is symptomatic, goes here, and you perform surgery for this or whatever, if you want to do a TAVR or whatever is the indication is. If you have like very severe, more than 5 meters over second, more than 60 the mean gradient, you also perform like any valve replacement here that you want. Is low EF asymptomatic, then you have to prove symptoms and prove that it's severe enough. Why is that? Because most of the time those people are not very active. For example, they're 70, they don't have like a very active life. So you have to make sure like they are symptomatic indeed. Symptomatic, you have like a high gradient, high flow. Those are going to a replacement. Low flow, low gradient, low EF, low vitamin stress test. And what about you have like low gradient, normal EF, or what is called paradoxical low flow? You have to do in those patients a calcium score. Now, what is a recommendation class one? Do a do a echocardiogram. If the physical exam show increased murmur, the murmur peaks later in systole or diminish A2 or increase hemodynamic demands. For example, the patient you has a history of moderate like aortic stenosis, echocardiogram 4 months ago, and goes to the hospital and has like some angstemia or some condition there. You have to repeat echocardiogram to see how severe it is. Now, uh, when you have D3, D3, remember, was a normal EF, low flow, but normal EF, optimize blood pressure. Systolic blood pressure less than 140, usually underestimate. So optimize the blood pressure before reassessment. Why? This is the diagnostic part. 2A recommendation. C1. C1 was asymptomatic. C1 asymptomatic, and this this one was asymptomatic. So you do like a exercise stress test. Exercise stress test to see if this patient has symptoms or not. D2. What is D2 is a low EF, low flow, low gradient, low EF. Do the vitamin stress test. D2 and D3, we already talked about. You can do DVI or CT scan. Remember, males more than 2,000 and females more than 1.3, 1.2. Here is a error here, 1.3. Class 3 recommendation, if you have D1, you already have severe, don't do a stress test because it's already severe. You're not going to have any other information of that. When it's severe aortic stenosis, you have like a free survival rate of 30 to 50% at 2 years. Aortic sclerosis going to severe 10% at 5 years is like the survival rate. Progression annually, the velocity is zero point 0.3 meters over second, gradient 7 millimeters, and decrease in area of 0.1. What does that tell you? For example, if you have like a velocity of 2, annually you expect less than this. So you don't need to repeat in 1 year if you have like a mild aortic stenosis and no echocardiogram. That's why I did recommend. If you have a progressive stage B every 3 to 5 years, if you have like a velocity 2.9 millimeters over second. Every 1 to 2 years, you have like 3.0 or 3.9 meters over second. Why? Because the velocity annually progression is 0.3 meters over second. If you have more than this, that's indication of that you have to do something about it. And if you have like asymptomatic stage C, severe asymptomatic, remember every 6 to 12 months, and if the velocity is more than 4. When you are going to treat a class 1 recommendation stage A, B, C, meaning asymptomatic, treat hypertension, starting at lower dose. Always treat hypertension. Remember, don't lower too much the afterload. Statins for standard risk. For example, if the patient has like some coronary disease, use statins, but the statins doesn't prevent progressions. Two recommendations also is ACE inhibitors, ARB, and all of that. Intervention, class 1, class 2A, and class 2B. Intervention, class 1, aortic valve replacement when you have like a symptomatic, causing symptoms. D1, D2, and D3. So meaning high flow, high gradient, low flow, low gradient, normal EF or low EF. So you are gonna have if that causing symptoms. If you have like a asymptomatic, but is C2 and the ejection fraction is less than 50%, you replacement. Or it is a C1 if the patient is undergoing another surgery, so you do a replacement. So remember, class 1 indication is all the Ds, all the symptomatic, irrespective. C2 if you have like the ejection fraction less than 50%, and C1 if you are undergoing another surgery. This is important for you to remember. When is class 1 recommendation? Class 1 recommendation this, C2 when the ejection fraction is less than 50%, and C1 when you are going to undergoing another surgery. 2A recommendation. If the patient is low surgical risk in C1. C1, remember, is asymptomatic, but the ejection fraction is normal. So you do exercise stress test, and if the exercise tolerance decrease or the systolic blood pressure decrease more than 10 millimeters of mercury at peak exercise, then you have an indication 2A, the patient is low surgical risk to undergo surgery. That's why, like in those patients in C1, asymptomatic patients, is indicated the exercise stress test. Also, C1, 2A recommendation when the BNP increase more than 3 times normal, so meaning like 300 pg over ml, or increasing more than 0.3 meters over seconds a year, the velocity, or is very severe, more than 50, or the gradient is more than 60. Remember, one, this, one class 1 recommendation, all these class 1 recommendations. C2 if the EF is less than 50%, or you are undergoing another surgery. Class 2A recommendation, if the patient is low surgical risk, you're going to do in C1, you do an exercise stress test. The exercise stress test is positive, meaning you develop symptoms, the blood pressure decrease more than 10 millimeters of mercury at peak exercise, then you may perform like a aortic valve replacement. Or the BNP is more than 3 times normal, more than 300, or decrease the aortic valve area more than 0.3 meters over second annually, or is very severe, more than 5 meters over second, or more than 60 meters over second. To be recommendation, C1 asymptomatic and decrease the ejection fraction on at least 3 serial imaging less than 60%. That's to be the recommendation. Class 1, you have to do it. Class 2A is recommended. Class 2B, you may consider. Stage B, 2B as well, is recommended to aortic valve replacement. So this is recommendation again, abnormal aortic valve with reduced systolic opening, symptoms due to aortic stenosis that we call stage C, is a severe aortic stenosis D1 is recommended surgery. If you have like a velocity less than 4 and aortic valve less than 1, right? You have like a left ventricular ejection fraction less than 50%, right? That is a severe aortic stenosis. Stage 2, you do a dobutamine stress test, and if that is positive, you do valve. If the ejection fraction is normal, so meaning like stage D3, you do usually like CT. The CT is severe, you may replace the valve. All the D's here, replacement. Then, no symptoms, meaning like C or B. B, you don't have like symptoms, you are not have severe, so then it's 2B recommendation. Don't worry about it. If you have like stage C, if the EF is less than 50%, surgery, class 1. If all the cardiac surgery, class 1. If you have like a C1 and you have symptoms and the patient is low surgical risk, you may consider a replacement. We're going to review what is SAVR, what is TAVR later on. If there's also 2A recommendation, more than 50, very severe, the BNP is more than 3, rapid disease progression, the decrease more than 0.3 meters over second, and is low surgical risk, is 2A recommendation. Now, what is the types of valve that we have? We have like mechanical, we have like bioprosthetic. Mechanical, bioprosthetic. When we use mechanical bioprosthetic, this is easy. Bioprosthetic lasts 15 years, risk of early surgery. But this is according to the age. For example, if the patient is more than 60%, 65 years old, 10% risk of 15 years of reoperation. Why? Because they use less. But if the patient is like 20 years old, that's 50%. So you don't want to put like a bioprosthetic valve in a 20-year-old guy because there is a 50% chances that in 50 years he has like a reoperation. That's why like you use mechanical valve. What is the downside of like a mechanical valve? You need Coumadin, you need warfarin for that. That's why like, you need like frequent checkups. Bioprosthetic valve, that's why like in less than 50 years old, mechanical valve is preferred over bioprosthetic valve. Also, 2B recommendation is doing a Ross procedure. Ross procedure is like the pulmonary valve. I'm gonna put it in place of the aortic valve, and I'm gonna put it a homograft in the pulmonary valve. What is the problem with this? Risk of aortic stenosis after 20 years. So you have to reoperate. That's what is 2B recommendation in this type of valve. So that's why it's less than 50 years old. Use a mechanical valve. You have to use warfarin for that. More than 60 years old is bioprosthetic valve is recommended. Why? Because like the risk of reoperation more than 60 years is just 10%. Now, when you have like 50 to 65 years old, it's either mechanical or bioprosthetic. It's according to the patient. Mechanical, if like you have like a secondary surgery, for example, the patient undergoes for a CABG for multiple disease, you may use mechanical. The patient has like a prior like a radiation therapy, you may use a mechanical. Usually bioprosthetic doesn't do well in those things. Now, if the patient wants to be pregnant and still in the age of like a that being like able to be to carry like a pregnancy in the 30s, then the patient may be choose like bioprosthetic. Why? Because this anticoagulation. So that is like the in a summary, in common guidelines, what we use is less than 50 years old, mechanical, more than 65, bioprosthetic in between is either one. If the patient is pregnancy, maybe you use bioprosthetic. Why? Because like you need to use like Coumadin, and the patient wants to be pregnant. No. Now, what is the bioprosthetic types? Mechanical, remember, is surgery. Bioprosthetic type, you have like surgical, or you have like the TAVR, which is transcutaneous. This is a surgical aortic valve replacement, transcutaneous aortic valve replacement. Class 1 recommendation for a surgical aortic valve replacement if the patient is less than 65 years old and the lifespan is more than 20. Patient is in C1 as well. Patient is asymptomatic and the and doesn't have symptoms, it's preferable to do like a surgical aortic valve replacement, meaning like the normal ejection fraction. No far favorable vascular anatomy. So, in a nutshell, when you use TAVR you use when the patient has like more than 80 years old and the lifespan is less than 10. Why is that? In the prior 2020 guidelines, because we didn't have like enough information. Right now, you are seeing like the TAVR is lasting 15 years, but we need more information about it. So, but right now, what is the recommendation is if the patient is more than 80 years old and lifespan is less than 10 years, choose TAVR. If the patient is less than 65 years old and life expectancy is more than 20, use TAVR. If the patient has like a C1, meaning it's asymptomatic and normal ejection fraction, usually use TAVR. And the patient doesn't have like a favorable vascular anatomy, meaning that has like a severe PAD, use TAVR in those patients. When you use, you can use TAVR or TAVR when the patient is 65 to 80. TAVR usually is preferable. Why? Because it's less paravalvular leak, less pacemaker, and usually like when you have like a low EF. D1, D2, and D3 also use TAVR. When you use a TAVR, it's going to cause you less stroke and less AFib, but it has higher risk of you require like a pacemaker. TAVR, remember, more than 65 and lifespan less than 10 years. 10 years. No data if the patient has less than 65 in the last guidelines. There is no data about it. Probably it's coming out like more data. So when you use the PAVD, which is like a balloon, when the patient is hospitalized and is a bridge to aortic valve replacement in critically ill patient, you can use a balloon like a valvuloplastic. You like open up like the narrowing of the aortic valve. Usually that you can see when the patient is critically ill. For example, the patient, I had like many patients who came to the hospital cardiogenic shock. They had like atrial fibrillation with RVR. they have like we don't know how to deal with this aortic valve, and the patient cannot go like this surgery because of high risk of mortality and this TAVR. We sometimes do those things for like a bridge to aortic valve replacement. This is to be recommendation. TAVR a contraindication. This is important. Why? Because it's recommended more than 80 and life expectancy less than year. But the life expectancy is less than 1 year, or the survival with benefits less than 25 at 2 years is contraindicated TAVR. Now, this is a summary what you have to do. I think like this is a straightforward. Basically, when you have aortic valve replacement, you have like two options: mechanical or bioprosthetic. Mechanical is less than 50 years old. The downside, you have to take Coumadin for that. It's more than 65 is a bioprosthetic. More a bioprosthetic, you have like a surgical, and you have like the TAVR. TAVR, remember, is more than 80 years old and life expectancy less than 10 years. And then like the TAVR is when you have a good life expectancy and the patient especially is more than 65. This is all for aortic valve. Please let me know which guidelines you want to go. This is based on the guidelines. This is based on like the latest evidence based on guidelines. And I'm gonna be happy to go through like a new suggestions. Thank you. Bye bye.